Okay, welcome everybody for coming to the Spine Conference. We have a small crew today, but we have a good crew. It's a solid inner core. We're going to talk about spinal implants because it's something that we deal with every day, and I think there's some confusion involved. And I know, Aaron, you're really interested in the topic, right? So just as an overview, people have been taking care of people since time immemorial. This is a picture of David in his internship, Dr. David in his internship, taking care of somebody's eye. Is that right, Dr. David?
Yeah. Yeah, eyes aren't what they used to be. You notice in the picture.
A general surgeon, when you're an intern, you took care of everything, right?
My eyes look forward.
So this is Dr. David taking care of one of the initial inhabitants of Harford County. Back when they were just farms. He probably had some kind of like farm thing in his eye or something.
Just say tear and they do it.
Okay. So the spine is made up of a column of cubes, and every single one of the bones in the spine is separate from the other. So it's good in the sense it gives us incredible amount of flexibility, but it's also can be bad sometimes because any one of these segments can have a problem. And if a segment has a problem, it can be terrifically painful. There's something about the spine that's richly innervated. So any of these bones can have a problem. So the basic premise is sometimes if the problem is it's weak or it slides or it shifts, etc., you want to weld the two bones together. It's called a fusion. So it's kind of, if you guys have any questions, just interrupt me. So sometimes you want to weld two of these or three of these or four of these or five of these together so they never move again. And so you don't have a problem. So the essence of a fusion is you shave the backs of the bones and you place more bone over it, and then Cami, I'm sorry, I didn't say good morning. Good morning. Okay. You shave the backs of the bones and you put bone there and they weld together and they fuse and they weld together. So that's the essence of a fusion. You can do this without instrumentation. So bones can fuse by themselves. But the instrumentation increases the probability of the fusion, of the fact that it takes place, and I'll show you what I mean. So this is a chain, but it's standing on end because it's been fused together. So every single one of these separate links has been welded together and fused, and none of them move. And this is the same thing as the spine. Normally it moves, but if you weld it together, it doesn't. So this is just, give you an example of what a fusion is. So bones can fuse. So this is Don. He got into a fight with me, and I hit him with my nightstick on his arm. He put his arm up, and it broke. So it hurts right here a lot. So it can heal by itself. It does have the capacity to heal by itself often, but sometimes not. So you see here, the fracture didn't heal by itself. It tried to heal, see the callus, but it did not heal. And this can be a source of pain. So I want to ask you, Don, I have my own theory about why non-unions cause pain. I have my own theory, and I know you didn't come prepared to answer this question, but do you have a theory of why, when a bone doesn't heal, non-union, why does it hurt?
Because there's movement there.
There's movement. And yeah. So how does the movement itself...
That's not a joint.
It's not a normal joint, right? So there's motion. So my theory is small fibered nerve endings grow into non-unions because those are the ones that transmit pain to the brain, and they grow into a non-union. Somehow they grow in there because. Good morning, Christina. They grow in because they're not supposed to be there, and they register as pain.
Where do the nerves come from?
Yeah, I don't know.
Not periosteum. It could be.
I don't know. I mean, the periosteum is richly innervated too. It could just be the normal. It could just be the sensation that's innervated from the periosteum, which the periosteum does have a rich sensation. It could just be the nerve and fibers from the periosteum. I'm not sure. Okay, but they do cause pain, and if you put a plate and screws across the fracture, and it heals, the pain goes away. And you can see, I think it's very intuitive that if you put a plate and screws across a fracture, it holds it still so that it will heal, because the persistent motion is what causes it not to heal. But it doesn't always happen, right? So here's a case where it didn't heal, despite the plate and screws, for whatever reasons. But this is a source of pain, because it didn't heal. And there's probably micromotion there. And eventually what happens, Don, with the micromotion, if there's still some motion there, and the bone never heals?
In this case?
Yeah, in this case.
The hardware will broken.
So the hardware eventually will break or loosen, like you said earlier, and the screws can loosen from the plate, and the patient still has pain. So the goal is to get it to fuse, like over here. So here's a picture of the spine, and I gave you all those examples so we can transition to this thought. This is a CAT scan, CT scan of the lumbar spine. This is the pelvis. This is the sacrum. This is L5. This is L4. And there are pedicle screws at L4. There's pedicle screws at L5, and there's a rod connecting them. There's also a screw at S1. So this patient had a fusion from L4 to S1. And you can see here, Aaron, what do you think of the bone from L5 to S1 right here where I'm pointing? Does it look fused?
It looks fused.
Solid fuse, right? It looks like the bone is continuous. But what does it look like here?
Not fused.
Yeah, and why do you say that?
It has more open space.
Yeah, some blackness, so it's loose, and we call it lucencies in radiographics. So it's not totally fused from L4 to L5, but it is from L5 to S1. So same patient from L5 to S1. See all that bone back there? But what about here, Aaron? Lucent, right. So he's got lucency at L4, L5. So this man never healed at L4, L5. And this is a source of pain. Does that make sense? Now just because there's screws across it, it doesn't help, because it never fused, so it's still painful. So you can, if you think back to the ulnar fracture, it makes sense now, right? How if you get a non-union spine, it still has persistent pain. Okay, so the talk is about Harrington rods, so we're going to start talking about it. So when I first started practicing, I told like a old radiologist, I'm going to fuse the spine. He goes, "Oh, you're going to use Harrington rods?" I was like, "What? Are you serious?" So it used to be that everyone thought all instrumentation was called a Harrington rod, and the Harrington rod probably was the first widespread instrumentation that was used, and it was a ratcheted rod with hooks. So you may say, why do you need that? Well, here's a patient with polio. And David, did you treat much polio when you first started practicing?
No.
No? Mostly orthopedic surgeons, right? Took care of polio.
Right.
But you saw it though, didn't you? Saw polio patients?
Very little.
Really? When did you start practicing?
62.
Okay, it was probably on the downswing at that time. But I remember my residency director said the biggest change he saw in his career was polio was gone. He said when he first started, there was a lot of polio, because they would come to orthopedic surgeons. How about in China? Is there a lot of polio in China?
Not right now.
Not really.
Yeah, when I start practice, there's not usually they affect the lower extremities of the different shortness of the neck.
Right.
Salk vaccine, I think, came out in '64. Does that sound about right?
I'm not sure the exact year, but I know in the 50s, a lot of people had polio. My cousin was born in Greece in the 50s. He has polio.
Where I went to college, our star basketball player died in 1962.
Really? From polio?
Oh, yeah.
Mm-hmm. It's a huge advance for mankind. So, okay, so this child had polio and had a tremendous curve. And it's hard to get that curve to fuse, but also these implants straightened it out. This is actually from Harrington. It went from 115 degrees to 64 degrees with the rods. So you can see there's a hook here and there's a hook there, one on either end, and through the ratcheted mechanism you can spread it and basically open up that curve. Does that make sense, everybody? So it goes from like a really sharp C to kind of like a broad-shaped C. So that's kind of how Harrington's rods worked. And then, again, you weld the bones together, fuse them, so the curve will not continue to progress. So you may say, well, who's Harrington? Who was that guy? So here's a picture of him. He was 1911 to 1980. He's from Kansas, and he was the national champion for javelin in high school. So it's kind of cool. And he served our country in World War II as a director of a surgical camp, and then he was in charge of a polio hospital, and he developed the first rod to straighten these children in 1953. And he's from Baylor, Texas. He was at Baylor from 1960 to 1990. 30 years, there were 1 million cases of Harrington rods. So you can just understand why everybody thinks all instrumentation is Harrington, because a lot of them were put in, and basically that was it for instrumentation. So the Harrington rods were great because they straightened out the spine, but they also caused something else inadvertently. On the side view, patients would get a flat back deformity, because on the front view they look straight, but on the side view, instead of having lumbar lordosis or sway back to the lower back, they were flat here, and that was a problem. But this was basically as good as you can get at that time. So here, this is what a spine should look like from the side view. You see how the lower back has sway back, and then the thoracic spine has a little bit of a curve, and then the cervical spine has a little bit of sway back too. And if you fuse it straight, as what was done inadvertently with the Harrington rod, your gravity line is pitched forward. So what does that do to people, Christina, when the gravity line's pitched forward?
It brings their center of gravity in front
forward.
of the base of support. So
and does that feel good?
Head, no.
What do they complain? Have you ever seen anybody with it?
Yeah, I mean, a lot of times then you have further issues up, particularly in the neck and everything too, because if you don't have that curve down there to support, it's difficult.
You lift your head up more maybe, so you can get hyperlordosis of the cervical spine too,
yeah.
and that causes symptoms.
Right.
Okay. So you can imagine, like, this thing doesn't look like it's comfortable, right? It looks like it wants to fall. You can imagine if the Leaning Tower of Pisa had muscles, the lower back part would constantly be trying to straighten itself out so that it doesn't fall down. Like a Leaning Tower of Pisa is not a person, but if it was, just think about it. The lower back gets exhausted because it's constantly firing to try to straighten up. Because people want to stand straight. They don't want to be leaning forwards. They can't see, and also it's just they're afraid they're going to fall. Okay, so we talked about Harrington. The next one's Lukey. Has anybody here heard of Lukey? Lukey rods? Okay, so Lukey rods. Lukey was from Mexico City, but he was trained here in the United States, and he developed the Lukey rod or trolley rod system. It's basically 2 long metal rods and then sublaminar wires under each lamina. So the wires that go under each lamina of the spine and then hook onto the rod, and then you suck the spine up to the rod to correct the deformity. And every single level got a wire. It's kind of a tedious process. I used to do it in my fellowship, and I've done some cases, actually, selective cases of this. So you can imagine, here's your curve, and you put 2 rods at every single level of the lamina. There's a wire, and then it attaches to the rod, and then you tighten the wires sequentially, and it corrects the spine. And you can get a tremendous correction in scoliosis with this. And then
how long does the surgery take for that?
You would think it would take forever, but you get pretty good at it pretty quickly. So it takes 4 to 6 hours. You don't believe me?
Still long.
Not for scoliosis cases.
Not for
No. You can get really good at it. After a while, you get the hang of it. You just pass them very quickly. And you need 2 trained spine surgeons. You can't do this by yourself. You need 2 people doing it. So that was the next advance in instrumentation was the CD rod or Cottrell. Here's Cottrell. Here's Dubuisset instrumentation for scoliosis around 1984. Now, Cami, when were you born in 1984? You don't want to say, right? That's secret information. That's kind of recently.
I was born.
You were born? So the CD or Cottrell Dubuisset instrumentation had a ratcheted rod, but had all these little hooks that would go onto the rod, and the hooks would attach at different areas of the spine, and you could correct the spine that way. So here's an example. All these different little levels, have hooks and then rods, and then you correct them through the hooks. So you push on the hooks, it corrects it, and you can also roll the rod. You can put all the hooks loosely onto the rod and then roll the rod, twist it, and then that can change the deformity too, so you can correct the deformity. Now again, it's most important to fuse the spine, but it's nice to get a correction too. All this instrumentation was developed for scoliosis, basically. So any questions so far about anything?
Is that instrument still in use currently?
CD? I don't think so. I used it in fellowship, but now it's evolved. It's CD was bought by Medtronic, so now it's basically a Medtronic product. Nobody uses it. There's newer products that are better, easier, and most people use screws now. Okay, so you can do tremendous things with instrumentation. This is a case of a flat back deformity. So this is a front view. It looks pretty good, right? But in the side view, you see how the gravity line. This person's trying to stand straight. The gravity line from her head is way forward from the pelvis, and the gravity line from T12 is way forward from the pelvis. So she's been fused in a crooked position, and she's had multiple surgeries. So all of her implants are taken out, and sometimes, I don't know why, but spine surgeons take out all the implants because they think if they take out the implants, somehow it will help. Like, I don't know why. Like, remove your foot. Like, it's kind of, to me, it seems like a little bit like just cleaning your footprints where you were. I have no idea. But anyway, she's fused in a forward position, and sometimes it's hard to get a good position in the spine. It's a different topic, but it just is what it is. And then to try to help out, the same surgeon went through the front of the abdomen and fused L3, L4. Now it's hard to see what's going on because of the deformity, but this is what she looks like. See how she's bent forward? That's the best she can do. And then you can see, I had her lift her skirt so you can see she had a hip flexion contracture because she's crouching so she can stay forward. So her back is always hurting and exhausting. So you can see what happened here. This patient had an L4, L5 grade 2 spondylolisthesis, which was fused in situ basically with screws, and then the surgeon took the screws out. And then the next level up developed L3, L4 spondylolisthesis. So the surgeon didn't want to go through the back side. He felt it was too complicated, so he just went through the front side and fused it from the front. Still crooked though, because he couldn't correct it. So now she's really crooked, and also her sacrum is inclined forward. It's hard to explain this, but she's flexing her hips and making her like rotating her pelvis so she can stand forward. So she's basically, her lower back is basically flat, and it's all fused too. It's a big problem. So here's the MRI scan. See how she's solidly fused on the side view. This is L3, L4, and she's solidly fused in the back view at L4, L5, and S1. And she's also very stenotic now at L2, L3. So it's kind of a very complicated case. So the best way to make her straight is to cut a big wedge out of her spine like that. And you can see if you cut a big wedge or a pedicle subtraction osteotomy, that'll straighten her out. So her problem was she had a flat back deformity. She had hip flexion contractures, which hopefully will improve as we correct her spine. Her sacrum's inclined the wrong way. She has no lumbar lordosis. She's fused posteriorly at L4, L5, and she's fused anteriorly at L3, L4. So, you know, it's a mess. So this gives you an idea of what a pedicle subtraction osteotomy. This is the back side, that's the front side. And you cut a wedge through the pedicle. You can take the whole pedicle out, and then you straighten it out. You bring it backwards, and you use instrumentation to do this. Initially, it was described without instrumentation and casting, which is would be very difficult. But with the instrumentation, it's easier. And you can correct a really bad deformity with the pedicle subtraction osteotomy. And this gives you an idea of the surgery is from the backside. Here are the lamina, all the screws are in place. You cut all this, and then you take the pedicle out. You have to be very careful of the thecal sac and nerve roots. And then you cut the pedicle out, and then you straighten it out through the instrumentation. And you always leave a little hole here just to make sure nothing is still compressed. So you can correct a huge deformity. You can get 35 degrees of lumbar lordosis through a pedicle subtraction osteotomy, which is a lot. So again, here's our patient again, and that's what she looks like. I drew it out on a piece of paper so I can understand it better in my mind's eye. And then I actually cut the piece of paper out to see what it would look like. And that's a nice, would you say, Chrissy, that's a nice sway back, if we can get that. So here's my surgical self-description. Whenever I do something, I write down what I did, and it's like, here's the yellow is the thecal sac, which was decompressed. This is the screws and why I put them there, and here's the post-op x-rays. It's like a bunch of implants. There's iliac screws, there's screws at S1. It was an L5 pedicle subtraction osteotomy. There's screws at L4, 3, and 2. And here's the CAT scan. And you can see there's a nice sway back now. She's upright. And this is where the pedicle used to be at L5, and it's been cut out. So you can see this line right here shouldn't be there. This should be a square. So here she is post-op. She's nice and straight, and then always the thing you learn is you always ask the patient to smile for the post-op. The pre-op you never ask them to smile, but in the post-op you always ask them to smile. That way it looks like you're a good doctor. These are all little tricks you learn.
And her pain was significant.
Actually, she did do dramatically better, like incredible. So any questions about, like, so let me just go into screws. So screws are made up of a bunch of elements. There's the head of the screw, there's the shaft of the screw, there's the inner diameter of the screw, which is sort of like, you can see the inner diameter, and then the threads poke out a little bit, and that's the outer diameter. And then from the pitch is from one thread to the next. That's the length of that is the pitch. So the way you put it in a screw optimally is first you drill. Here's a drill bit. You drill the same size of the inner diameter, and then with the tap, you tap the outer diameter, and then you insert the screw. Does that make sense? So that's how screws work. So here's some of the earlier screws that were just looked like a screw from the hardware system, and the head was basically just an extension of the shaft. But these, and this is how they got, they evolved a little bit, but these were difficult to line up because you had to line them up just right for the rod to work. The newest screws now have, most of them have variable angled heads, and that makes it a lot easier to line them all up to put the rod. So I have an example. Here's an example of a screw, 2 screws and a rod, and I'm going to pass around to everybody to take a look at it. The variable angle helped a lot with the surgery, and you'll see what I mean. So this is steel. So who can guess how much steel is created every year in the world? How many pounds? Just guess. Cammie, what's your guess? Sherry, get 10 pounds steel a year? David, 1,000,000 pounds? Trillion pounds?
A lot more than that.
1.3 billion pounds.
Right.
That's how much steel the world makes. So what is steel? Do you know what steel is? So I didn't know. I had to look it up. So steel is made up a lot of iron. That kind of makes sense, right? But they all have to have all these components. I can't even see now. Manganese, carbon, nitrogen, phosphorus, silicon, aluminum, sulfur, and oxygen. So that makes up steel. So are the pedicle screws made out of steel?
They used to be. You're talking about stainless steel now.
No, I'm not talking about stainless steel.
Regular
It's
steel.
just stainless
Regular steel? What?
Just regular steel.
Yeah.
I'm asking a question. Are pedicle screws made out of steel?
Important,
The answer is no. They're not made out of steel, right? Because they would rust. And that would be really ugly looking in the spine, right? They're not made out of steel. So like David said, what are they made out of? Oh yeah, they're made out of stainless steel, which doesn't rust. And here's a picture of David's car on the parking lot. Before he came in, I took a picture of it.
Never drive it though.
And it has chromium in it, so a certain percentage. So I think the definition of stainless steel, I looked it up on Wikipedia, it's greater than 11% component of chromium. Is stainless steel, which doesn't corrode and doesn't rust. But also it has a whole bunch of other characteristics: fatigue strength, ultimate strength, elastic limit, Young's modulus, which at some point in time in my life I totally understood, but now I don't really understand so well the differences. But the things that the alloys that we use now in spinal implants are stainless steel, very rarely. And who can tell me why we don't use stainless steel anymore? Is it because it's strong, too weak, too strong? Who can say?
Impair the imaging.
Yeah, impair the imaging. So you cannot get an MRI scan with stainless steel because everywhere where the screw is completely black. So you just, and it's a problem because people need more imaging because they have recurring problems. So the titanium screws were created that are a lot better with the imaging. So the titanium throws off very little scatter. And some screws also are made out of cobalt chrome, which is just another alloy. So here's stainless steel, which is the original screws, and then most screws I think now are made out of titanium, which is and I think it's not pure titanium, but mostly titanium, which throws very little scatter off with the MRI scans, but very little scatter with CAT scans. And some of them are made out of cobalt chrome. And which one's better for MRI, I'm not sure. I have to read up on, because somebody told me that cobalt chrome is good for MRI, but now Sherry says it's not, so I'll have to look it up, see which one's better. What?
I heard it was not.
It's not good for MRIs?
It's in between
It has
titanium
scatter.
and steel, if you're talking about scatter.
Okay, I believe you guys. So cobalt chrome is mostly what hips are made out of, I guess. It's a good implant for cycle forces. These are hip replacements. So this gives you an idea when I say variable angled head. Here's the screw shaft and the threads of the screw, but where the shaft meets the head, it moves. And this is just one screw. There's many different types of variable angled heads, and that makes it very easy to line everything up. So this is from Ghost Productions. I don't know who that is, but they let you have. So this shows you like how it works in the spine. So here's yesterday's patient, and he needs a spine fusion for whatever reason. I won't get into that. So these are the posterior elements of the spine, back as far as the spine. First you have to drill a hole, and then make the hole with the drill, then tap it, and then insert the screw into the pedicle. Now the only thing that's visible is the head, because the thread portions in the vertebral body are the bone. So you put different screws, and all the little heads can rotate to line up the rod. And then once the rod's in, you place caps onto the top of the head, and that tightens the whole thing. And you do it on both sides. So that's why the variable angled head helps a lot, so that the rod can line up. Anybody have questions about that? So I think that kind of like helps you understand.
And before the surgery, you know what you're going for, like as far as angle and everything else, and the rods are selected to line things up the way you want it.
Right, and originally the rods were just straight rods, and we had to bend them.
Okay.
But now the companies have pre-bent rods.
Okay.
But I very, very frequently have to bend them myself too, so I make a little adjustment.
Okay.
And also the variable angled head makes it much, much easier. But you still have to eyeball things and see if they'll line up while you insert it. But you have to insert it in a certain place. You can't just put it anywhere. So this gives you an example where you got to insert it. You got to insert it into the pedicle of the vertebral body, the screws. You can't insert it in the canal because you'll hit the nerve. So you see this screw, it's pretty close. It's only off by a couple millimeters, but that's terrible now because the patient has horrible leg pain. So it's got to be really, really well placed. So you do have a little bit of leeway, maybe a millimeter or two, how you can insert it. Mostly the depth you can change, but it's got to be right on. So you're basically limited by the confines of the anatomy where you can insert these screws, because you can't hit the nerve roots. And if you go out the outside way, then the screw's not strong because it doesn't have much of holding strength. It's got to really be dead center into the pedicle, then into the vertebral body, really to have the best implant strength. Does that make sense? So here's an example of a screw that's hitting a nerve root. And that's why we frequently get CAT scans. As any time that any patient has leg pain post-op with screws, we always get a CAT scan to make sure, like this screw, it's pretty close, and yet this sharp metal thread could be hitting a nerve root, in which case it'll give the patient terrible leg pain, and it's a serious problem.
You do imaging intraoperatively.
Their upper Chesapeake has an intraop CAT. I mean, I do X-rays. I do fluoro frequently.
Yeah.
Upper Chesapeake now does have one machine.
Like a C-arm.
It's an intraoperative C-arm.
Yeah.
It takes 30 minutes though. So
do you do it at each level, or do you wait till you're all through and take one image, or several images?
Some surgeons do it during the surgery, so they use it as a helpful guide of inserting the screws. I just do it at the end because I've been doing this 15 years, so I don't really need the machine to put them in, and then I check them afterwards. And it's rare that I'm off, but I mean I think it's too burdensome during the operation, increases infection rate and increases operative time, for it to be very helpful now for every case. But I think, I mean, in some selected cases, maybe it's worth it. The machine will probably get better in the next 10 years, I would assume. But I think it's pretty good though if you're not sure of something, and do it at the end to check all of them, and then just switch the ones out that don't look right. I think that's the best cost benefit. You know.
Is there 3D imaging now, or is that being developed?
Live 3D imaging? Live or
yeah.
just?
Yeah.
I don't know. Do you guys anybody know?
That was
That's 2D.
It is 2D.
I've seen
Well, it's 3D.
3D
Wait a minute. CT is 3D because you can go through the levels. See what I mean?
It's circular.
I don't think that exists. I mean, you need a hologram for that.
There's a technology out there that hooks into some microscopes where you have to wear like the 3D glasses, like when you go to a movie theater, and you look at the screen, and it is 3D in that aspect. I've seen that before, but that's really, I mean, CT is already 3D, but if you really want 3D, true what we think of 3D, the technology is out there.
The other problem that can happen with screws is they can break. So if the spine doesn't fuse, we already talked about, the screws eventually will break, just like a clothes hanger breaks. If you bend it enough times, it will break. And it's not a matter that the screw wasn't strong, it was the fact that the bone didn't heal. And then if the screw doesn't break, and most screws, I have not seen a broken screw in a long time. What happens is that the manufacturers have worked with the alloys that they're really good now. They're really strong. So what happens is the screw doesn't break, but you get halo loosening. So you see that? You can see if the bone never fused and it keeps wiggling and shifting, it creates a little hole in the bone, kind of like a windshield wiper. If it goes back and forth, back and forth, back and forth, it works a hole into the bone. And this is called the halo loosening sign. So this is what you usually see now in spines. Usually the screws don't break.
What do you think the main reason, like the lack of precautions or smoking, or what do you think the main reasons are for failure like that?
For non-unions, cigarette smoking is a very big cause. So if someone smokes, we usually blame that. But sometimes it just happens. So sometimes the bone doesn't heal. It's just not. It's not a bone that's very conducive to healing the spine. There are some portions of the spine that fuse very, very often, like cervical spine. Anterior cervical spines have a very high fusion rate. And I don't know, Don, what bone do you think is the best fusion rate in the whole body? All of them have non-unions.
Yes.
There's no guarantee.
And just for head, I mean the intertrochlear fracture.
Intertrocks, very. I've never seen a I mean, they probably don't come to me because they're angry, but I've never seen an intertroch non-union. It's cancellous, and the instrumentation we have is very good, and we're good at putting them in too. I mean, everyone's pretty well trained. Yeah, so intertrochs almost always heal. When I say intertroch, I mean intertrochanteric hip fractures. But all of them may not heal, and why? Sometimes they don't. I don't know why. It's a multitude of factors. It has to do with the instrumentation. It has to do with the bone quality. Like a cancellous bone or the spongy bone heals a lot more often than a cortical bone or a thick bone, and there are more cells there. There's more bone morphogenic protein. I mean, what the patient does help too. You got to stay still for it to heal, but sometimes just totally normal people don't heal. It's just, I'm not sure why. What can you think of any other reasons, Don, why people?
So you guys after surgery usually the patient don't wear the external support.
I don't do the clamshells anymore.
Yeah.
I don't think people hate them. They complain. The only person that can wear those things are kids.
So the patient after surgery, they probably do heavy lifting or some bending, twisting, that kind of stuff that can affect the healing rate.
Yeah. I think if you do a really good job with the fusion, you put the bone in exactly the right place, you get iliac crest, you're meticulous in your technique, almost everybody usually fuses, the high fusion rate. Okay, so this just gives you a show of what's going on in the, and you guys, Sherry and Cammie, you can chime in if you have any questions, but this is the whole market for spinal implants. It's mostly dominated by posterior pedicle screw systems, which we talked about. But there's also anterior cervical plates, there's T-lifts, anterior lumbar interbody fusions, posterior lumbar interbody fusions. I don't even, what's ISP systems? I don't know what that is. Huh? Interspinal system?
The spinous process.
Oh, the spine, man, 8%? That's incredible.
That's pretty high.
Artificial discs, cervical artificial discs, lumbar artificial discs, vertebroplasties, kyphoplasties, balloon, allograft, it's 10%. DBM is 11%, it's incredible. And BMP is 9%. And this is the people are prognosticating what's going to happen in the future. Is that artificial discs will increase, but pedicle screws are going to increase too, from a percentage. And probably just because we're getting older as a population. So, who's dominating the market? Sherry, it looks like you're number 2, man. But you're not. You just sell this stuff, right? You're not that company, but number 2. And Cam, you're not even on the list.
I'm in the rest.
You're in rest. You're in rest, but that's okay. You're nice.
Rest.com.
Yeah. So it looks like nationally, Medtronic, DePuy Synthes, because they combined last year. That's why they're so big. Stryker, Nuvasive, Zimmer, and then Rest. And Cammy's like, what do you like, a little slice right here?
Well, at least we're 21%.
Yeah, when you guys get together, you're big. Okay, so another thing is what's going on in society is like everyone's getting fusions. So here's operations per 100,000 adults. In 1988, you can see there's 20 people per 100,000. That's when I graduated from college. And then for elderly, for people 60 and older, there's only like 15. And now 2001, that was a long time ago actually. That's 12 years ago. It had gone up like 9 times, or 8 times. It's unbelievable. So remember the CD instrumentation came out in 1984. So they didn't really have much. They didn't have implant systems that you can do a fusion. But since these implant systems have improved and are easier to insert, and more people are trained to insert them, the rates of fusions has gone up tremendously. And also, not only has the number of lumbar fusions gone up tremendously from 1998 to 2008, but the costs have gone up tremendously. So these are the average amount charged by the United States Hospital for lumbar fusion surgery has gone up really high. And the number has gone up. So this is like an incredible amount of money that we're spending in our society. So this is an article in the Wall Street Journal, I think it's 2010. And it just reviews different hospitals in the United States and how many millions of dollars Medicare, not all insurance carriers, but just Medicare paid the hospital. And number 1 is my alma mater, Johns Hopkins Hospital, 59 million. But if you look at the percentage of fusions on patients with Asian discs, it was only 8%. So most of the patients don't get fusions. But the highest percentage of patients getting fusions when they ever have the spine surgery of 24% was at Norton Hospital in Louisville, Kentucky. And then if you look at the people doing those fusions, they're all on the payroll for Medtronic. They all get $1.3 million a year. Now they get this money because they do consulting for the companies, and they spend a lot of time consulting for the company, and they do work for the company, and they also have royalty rights. They created implant systems. So every time a patient uses a screw in another part of the country, they get a royalty. But it is a little suspicious that 24% of their surgeries all get fusion. So that's why the Wall Street Journal went over this article. The other interesting thing is global unit volume and average selling price. The selling price is, they estimate, is going to go down for the instrumentation and maybe level off. I think this is per screw, like $500, but the volume is going to just keep going up as more and more people have spinal surgery, and the reason people get spine surgery. Who can guess? More people like me who are trained to do it, more elderly people who need spine surgery? Because usually the spine deteriorates as you get older.
I think people's expectations to be independent for more of their life is greater. People work longer and everything else too. You know, where people before
Could be.
maybe weren't even willing.
Yeah, it could be expectations that people expect to play golf and play basketball into their 80s. I don't know. So this just goes different parts. We went over this. And this is an interesting graph of the global spine market per segment from 2010 to 2020. This is just what somebody's guessing. So this is what it is now. And again, it's dominated by the posterior pedicle screw systems. And all the different aspects of spine surgery, all these things are sold to hospitals. And this is what they project it to be in 2020. So they project it not to double, but almost. So as of March 23rd, 2010, this is the signature on the Healthcare Act. So we're all going to get insurance. So is that good for spine surgery or bad for spine surgery or society? What do you guys think? Affordable Care Act. David?
All premiums are going to go up. You know that we're doomed.
We're doomed? We're all going to die? We're just going to be eating beans and rice and have spine surgery?
But, well, I don't know if more people will be insured. A lot of companies will be dropping plans for their employees.
So we're all going to be on the national dole?
Making more part-time employees. I think that's the argument.
And then they don't, like Walmart. Yeah, like
right.
Walmart workers are all part-time. They don't get health care maybe. I don't know.
So I think overall it's probably not a good thing.
But they all get health care through the government. You're basically guaranteed it.
Doesn't mean
well, your taxes are going to be higher, and you're going to pay more for your private health premium.
Or if you can't afford it, you'll be on the national.
Right.
I don't know what's going. I don't know what's going to happen. I know one thing. I'm scared. How do you guys feel about it?
I don't know.
Has Paul
as expensive as a spine surgery is going to be covered. You can't just because you have.
I know.
I mean,
they're really expensive.
Right.
Well, they'll say if you have a deformity of your spine, so what?
No, you know what they say. You know
what happens when you get old.
No, this is what they do. I'll tell you what they do because I see it. Is like if you have back pain, you cannot get an MRI for 3 months. They won't let you. Some carriers. It was one case. I think it was Aetna refused to let the patient have an MRI. She was in horrible pain. Turned out she had an L4 fracture.
Wait for what, spontaneous cure?
Wait that she'll die. Maybe she'll die. Maybe she's having a bad day.
Maybe it'll get better on its own.
Maybe it'll get better on its own. Maybe she just had a fight with her husband, and she'll feel better the next day. But they made her wait 3 months. It turned out she had a fracture, and it was just a horrible 3 months because she kept screaming at me. I was like, my hands are tied. And she said, I don't have the money. I was like, well, I can't help you. I mean, so I think they're going to just deny the first step. You can't even get into the door. You can't even get an MRI. You can't even see what's wrong.
You need a legal case that has some detriment based on the decision that the insurance company makes.
Yeah, but the government, everyone's going to do it. Everyone's going to, I assume, I mean, this is a political discussion. I assume everyone's going to be in lockstep with Medicare. Medicare is going to make a rule, and then we're all going to say, well, we're following Medicare rules. Because everyone can't have spine fusions. Right. Otherwise, we're just going to be eating beans and rice and living in rags, and everyone has a spine fusion.
Right. Like with joint replacements, they're requiring 12 weeks of conservative treatment prior to the joint replacement being approved.
Right.
But then they're capping therapy.
Right.
$700 max.
Right.
But
a lot of people.
It's less than that. But then you can approve if you have to jump through all these hoops, which we are. But it's really okay, we know that this patient needs a joint replacement, but
right.
You're going to use up all their dollars prior to surgery because of this requirement. But then you're going to say you have it capped afterwards, and
it's the best they can do to somehow limit it.
Right.
To just don't jump to. It's the only way that they can do it, I guess. They just don't jump to the joint replacement immediately.
Right. And there are patients, but it's craziness.
Okay. So any questions? Did anybody learn anything about spine implants? Did you guys like Prezi better or PowerPoint?
This was smoother in my opinion.
Smoother?
Except
PowerPoint and
the thing
Prezi?
that keeps coming up to full screen.
Yeah.
I mean, just
The whole thing crashed 5 minutes before, and it somehow it just came back up.
This?
What is
Yeah.
Prezi?
Prezi? Something new. You like Prezi or PowerPoint? Cammy, what do you think?
It's a PowerPoint
It is.
thing.
It's a presentation. It's a way to present things.
Okay.
What do you prefer?
Is it open software?
Yeah. No, I don't know if it's open or not, but you get it. It's free. Would you like this or PowerPoint? No,
I
no.
like this.
This one's better. How about you, David? What do you think? PowerPoint or Prezi?
I like today's.
Prezi better? You like Prezi better than PowerPoint? See, I like PowerPoint better.
well, the videos and stuff.
The
it seems
videos-
like a smoother
Yeah,
transition
the
to that.
transition. but
with
new
this.
PowerPoint 2013 is really good.
Okay. I don't.
This all depends on how easy it is for you to develop this presentation too.
The-
For us to sit back and watch it is one thing. You've got to make it. If it's
Yeah.
PowerPoint.
Yeah, I don't know. It's pretty cool though how you can just go from slide to slide. And I didn't. You can also get like go within other slides. And it's all on a big background. But anyway, I don't know. I'm probably going to go back
That's
to
the
PowerPoint.
only thing that I would say that Prezi.com, like, is there any way to make that not happen?
No,
Exit full screen mode.
no way. It's free. They got
Right.
to
Yeah, you got to do something.
they got to
Gotta
they
get
got to
your
make
name
their
up
money
there.
somehow. I don't know. I thought it was a little experiment. Okay, thanks everybody for coming.
Thank you.
Thank you.